The Center for Behavioral Intervention Technologies, joined with co-lead Jessica Schleider for this webinar series. This is our final one of the 2024-25 academic year. We are closing out strong. I'm very thrilled and honored to introduce Nathalie Moise, an internist, associate professor, and director of the ImSci Lab at the Center for Behavioral and Cardiovascular Health at Columbia University in the medical school. She's been working in health services research for more than 15 years and is MPI or PI of several federally funded grants from a range of institutes, NIH, AHRQ, PCORI, leveraging hybrid effectiveness implementation trial designs to study the implementation and de-implementation of strategies for promoting behavioral interventions. The ImSci Lab conducts hundreds of implementation science consultations internationally with policymakers, industry, healthcare systems. So really having wired for impact. I love this title. And she co-leads the CTSA Implementation Science Initiative, is a founding member of the American Heart Association's Implementation Science Committee, and co-chair of the AHA Healthcare by Food Community Engagement and Implementation Science Task Force. So thrilled to have you here. Thank you. And we look forward to your presentation.
Great. Thank you so much for your great introduction and for inviting me over. So as Andrea said, I lead a variety of different interventions, and really my work is really focused on developing models for designing more scalable, mechanistically driven, multi-level strategies. I know a lot of you are focused maybe on the digital health space as digital therapeutics, but my focus really is on using digital health to improve the uptake of evidence-based interventions. So I'll be telling you about two of our projects that we finally have some results on, DepCare and iHeart. So I'm going to start with a question. I don't know if we can do in the chat. I'm not sure if I'll even be able to see it, but first question is, in your experience, what's the single most important factor that determines whether a mental health treatment, this could be digital or otherwise, is consistently used over time and not just adopted once?
This is cool. We've never done interactive on a webinar. If people can write it in the chat, it should go to everyone, I think.
Great.
We may not be poised for this kind of setup. I know. This is awesome, though.
Call it out if you want, but so my premise really is a key piece here is really adaptation. And so if you think about iPhones, they're constantly updating, they're constantly changing. And so really the premise today, a little bit of our talk is really going to be around, I'll highlight some gaps in designing implementation strategies, give you a little bit of background for implementation science, describe a model for designing digital health solutions for sustaining evidence-based intervention, and then provide two use cases for validating the model. And so the core message really is that theory-informed digital health solutions that promote iterative adaptation is really key to sustainment. So some gaps in the field. Now implementation science has been around for a little while. And so as you guys know, there's this kind of gap between what we know and what we do. And the core of implementation science is that there are these evidence-based interventions. They could be CBT, CBTI, digital health interventions now have a lot of evidence behind them, which are very different than the implementation strategies. There's the bundle, the stuff that we use to get people in places to use those evidence-based interventions. And so the key things that we're looking at are things like feasibility, fidelity, acceptability, and context is key. How did this happen? Why did this happen? Why did this happen? Why did this work in this setting and not that setting? What do you need to make something actually work in not just in theory, but in reality as well? And so now there have been lots of different publications around how to do and conduct implementation science. Many of us have published around incorporating equity into how we do the work of implementation science. You select an evidence-based intervention, you identify barriers and facilitators, you select and use and adapt the implementation strategy, and then you evaluate this. So now we've been around for about, at least 10 plus years, maybe almost 20. And so this has allowed us to have a little bit of an historical overview of the field and where we're going. And so historically, the field has really focused on building shared language, creating frameworks, models, theories, repositories of implementation strategies like ERIC, right? We know what the list of implementation strategies there are for us to choose from, but they haven't always been validated or vetted or applied well. How do we know that using this framework actually leads to real change? How do we know that it actually made a a difference in terms of using this model or this theory. The other thing is strategies have often been tested. So I call them often these co-interventions, right? The things, the bundle that we use to get people to use an evidence-based intervention have often been tested one level at a time, right? So mostly at the physician and organizational level, and often for one disease at a time. And there have been very few multi-level strategies and very limited kind of theory-informed justification of why did you choose this strategy. And then lastly, they've often been shotgun or kitchen sink is how I describe them, right? And so you end up with these imprecise strategies. It's unclear what worked, what component was actually necessary, and now you need to actually sustain that strategy just because it was so complicated and convoluted for us to kind of use. So there have been some efforts to better match strategies to barriers. I don't know if any of you know CFR, right? And so you have all of these different barriers, capability, financing, and you can map them to an implementation strategy. And now there are strategies for sustainability that you can choose from as well. Maybe you need education, maybe you need funding, audit and feedback. But what happens if everything's a barrier? What if you come up and you come up with a huge laundry list of barriers? You end up with these strategies that are very, very complicated and imprecise often. I've often also done some work around using conjoint analysis as another way to choose strategies, right? So you can imagine asking stakeholders, do you prefer option A, where you're getting some audit and feedback and educational presentation versus implementation team and maybe doing a local needs assessment? You give them a series of questions like this. And by the end, you can say, hey, they will often choose the option where audit and feedback is there. And so what ends up happening with this mechanism, this way of designing implementation strategies, is that you end up with something that people really like, but may not work in theory, may not be what they actually need to get the work done. So there was a recent review by Cochrane of all of the implementation strategies. And so this is reviews of review of implementation strategies in healthcare. And now we're starting to get a sense of what works. You need some education, you need local opinion leaders, you need reminders, audit and feedback, information and communications technology. Most have been multifaceted, right, and very complex. And so at the end of the review, they said, we need to move away from what works to what works where and for whom, and to have more theory-informed approaches to explain why was this chosen and how did it actually work? Did it work the way that you thought it was going to work? And what were the costs and economic settings that you actually needed to have in place for this to work, and which people often don't report or think about? And then lastly, there have been very few kind of step-by-step sustainability guides. Like, how do you design for the long run? How do you design something so that you can make sure that something keeps being used over time and not just kind of thrown to the side? I think Andrea and others in this group have also looked at implementation strategies for digital health, right? So now there's a lot of great evidence for digital health interventions. And we're starting to realize that just digitalizing something, an evidence-based intervention like CBT, et cetera, doesn't mean that it's going to be widely implemented. You often have unique barriers, and thus unique implementation strategies are often needed. And I think Andrea kind of scoped out in one of her papers, you might need design referral processes, fidelity monitoring, safety monitoring, technical assistance, all of these things that might be unique for trying to get people to use a digital behavioral health intervention. But these are also prone to kitchen sink, imprecise implementation strategies, and maybe even more so. You can imagine throwing the complete kitchen sink. We're trying to get someone to use this entire healthcare system to use a novel digital behavioral health intervention that we know it works. Maybe even more likely, you're likely to kind of throw the kitchen sink at this, and you're still ending up with these imprecise implementation strategies. And even more so, sustainability, I think, continues to remain elusive. So a couple years ago, I put together a model for designing more precise implementation strategies for sustainability. And at its core, it's a combination of one or two frameworks where we really think about a lot of the times our evidence-based interventions are already in place, like collaborative care or CBT. They're already kind of being used, and getting a sense of what's working, what's not working, and really thinking about it in behavioral terms is something that we are proposing in our model, and then mapping those to behavior change techniques and strategies before incorporating some user-centered design to kind of really design these more precise implementation strategies. And so the premise here of this model is that first, first is based really and seeped in the dynamic sustainability framework, which was proposed by David Chambers and others. And the premise is that you can't just keep an evidence-based intervention the same. You have to keep adapting it to a local practice, to the ecological system over time to kind of fit the needs of your population. Some of the barriers to this has been that there hasn't always been incorporation of the need for sustained behavior change and thinking about behavior change. And it's often a little abstract. It's unclear, how do you actually get this done in reality? This kind of adaptation process in theory, right? And the other piece is this, you need to include these multi-level behavior theory and forms. So many of you might also know Susan Michie's work of the behavior change wheel. This has often been used to design interventions for obesity, for weight loss, for example. And so it's really focusing on just one behavior with the greatest spillover, right? So if I were to target this one behavior at the system, maybe it's the provider, maybe it's the patient, they're the reason why this evidence-based intervention isn't being widely implemented. You look at all the barriers and then you map that to intervention functions and behavior change techniques. And what's nice is that these behavior change techniques, there's a lot more understanding that these overlap with ERIC strategies, with implementation strategies. So you can imagine designing implementation strategy using this. But what's really salient about this model is it forces you to just choose those behavior change techniques that meet these criteria. They have to be acceptable, practical, efficacious, safe, equitable. If they're not, then you kind of throw them to the side. So it allows you to really, really start focusing and creating something that's very much more precise. People are starting to use this a little bit to design implementation strategies. And I think our group has really focused on using this to design multi-level strategies. Let's pick one behavior at the system level, one behavior at the provider level. Is it referral, or is it the discussion, or is it which component of the provider's various behaviors is the most important for us to kind of target? Same for the patient. And so our group has really been at the forefront of kind of using this model and this trans-theoretical framework, really is how I call it, to design more multi-level strategies for improving the uptake of evidence-based interventions. Some of the issues with this has been that it doesn't really always think about sustained behavior change, right? It's not baked into this framework. And so pairing it with the dynamic sustainability framework and really prioritizing those behavior change techniques that we think could lead to sustained behavior change is one novel way of using this framework. And then lastly, the other big part of our model is really thinking about leveraging user-centered design. So we know this has now become at the forefront of implementation science. We need to do more of this, right? And so we have these complex psychosocial interventions, both digital and non-digital evidence-based interventions that are often not developed using user-centered design. And we know that implementation science has historically focused on organization and system level barriers and not on the evidence-based intervention itself, the characteristics, the usability, the individuals who need to use this. And so there's been a lot of interest of thinking through of how do we redesign and promote the usability of an evidence-based intervention, its efficiency, reputation, reducing the cognitive load, and maybe even using user-centered design to select evidence-based interventions, right? Let's select something that fits our context and maybe make some changes to the workflow or the EHR to improve the receptivity of this evidence-based intervention once it gets here. Less often done is really thinking about, can we use this also design strategies, right? So there is an overlap between implementation strategies and user-centered design. Things like co-design solutions, that in and of itself might actually lead to an increase or an uptake of evidence-based interventions. And starting to think through, how can we actually use this to design more precise, especially if you're using digital health in your strategy for improving the uptake of evidence-based intervention is really kind of salient. So this model combine user-centered design, the dynamic sustainability framework, and the behavior change wheel to really think through of a step-by-step process that was a little bit more accessible to folks of designing strategies for sustainability, especially if you're using digital health in your implementation strategies. And the gist of what we were trying to say in our paper is that successful implementation needs to work for everyone, right? Ozempic is a really great use case. It needs to be something that works for policymakers and industry. It works for doctors. They love giving it to patients. It works for patients. It's something that works for everyone, and it hasn't required a lot. And how do we do a lot more of that in the kind of work that we do, as well as something that's been quite salient to many of us? So the next step after designing this model is to start thinking about, how do I test this to make sure it actually works. Does using this model lead to more improvement in outcomes? Does it help me understand why my strategy worked and where it worked best? How does it work? Does it work or not? Right. And so I chose the collaborative care model because it's tried and true. It's been around for a million years. There's several meta-analyses showing that it's effective. And so the premise really is that you have a care manager who's in a primary care setting, and they're under a psychiatrist kind of oversees that care manager, and they do problem-solving therapy and measurement-based treatment. So treat to target for patients. So you screen an entire population. You work with the primary care doctor to titrate medications, and it's been shown over and over again to improve engagement, improve depressive symptoms, improve remission rates. It's tried and true. It's increasingly reimbursed across the board, and more widely available across the US, both commercially and so this seemed like a perfect use case to think about sustainability, right? So it's already there. Let's start thinking about how do we sustain models like this. And so 2012, I think in probably one of the largest demonstration projects in the US like this, the New York State Office of Mental Health implemented collaborative care. And so they threw the kitchen sink at the problem. And so they're like, okay, let's give these sites, we're going to start with 32 sites across the state. We're going to give them training and technical assistance, funds, quality monitoring. And then we're going to scale this. We're going to make this baked in. We're going to provide the one thing that was missing was reimbursement from a Medicaid perspective. And so they would give sites 75% of the money if they could enroll a patient, and then additional 25% if they could show improvement. And I came on in 2016 to start thinking through. It was a perfect use case of thinking through some predictive models and barriers to sustainability, looking at mechanisms. I've oversaw some of the cost effectiveness analyses. Unfortunately, it was not cost effective for the state, but and started thinking through of using this as a way to kind of design strategies for sustainability. And so what we found is that early on, it worked. So in those early 32 clinics, you see this improvement in screening rates, and you see a clinical improvement rate in depressive symptoms similar to the original clinical trials. And that's really what the hope of implementation science is, right? You're going to throw this kitchen sink at these sites, and you're going to hope that you're going to see the effectiveness that you saw in the original clinical trials. And it worked. And so as we started thinking through what were the mechanisms by which that worked, it was pretty clear that some of the early implementation barriers, I conducted interviews across about 8 sites with 32 individuals, primary care doctors, patients, care managers, psychiatrists, and to get a sense of like what were some of the barriers now, 2 or 3, 4 years into implementation, what's still here. And so things like training and knowledge and IT and funding were less often mentioned. And so those are some of the early implementation barriers that we actually often saw in those original trials or the original implementation trials. It's like, oh, we don't have funding, we have no training. And so this became the mechanism perhaps by which this kitchen sink strategy was working. But what ended up happening is that there were still lots of barriers, and the salient barriers that maybe weren't targeted by those strategies were things like provider and staff engagement, patient engagement, and personnel resources, particularly in the opt-out clinics. And so we looked at the original 32 clinics. By then, I think now we're in like hundreds and hundreds of clinics across, and about 80% of the FQHCs across New York State, and about 80% of clinics stay in this program, which is great. But what about the 20%? To learn a little bit more about those opt-out clinics, we went and talked to them as well. And so what we found is that, things like it's impossible to do this here. We only have one counselor for all of the patients. Nobody thought about the logistic issues, no thoughts of sites. Psychiatrists are not motivated or interested in doing this. And so in those opt-out clinics, it became pretty clear that this is just a poor fit. And this gives you some context. If you're trying to design something or implement something novel, learning what didn't work in a setting can give you a lot of context as well. Maybe they needed a different strategy, or maybe they needed a completely different model for providing mental health care in their setting. They had very, very low fidelity, but was very clear, though, that without the kitchen sink, they had very low fidelity, the collaborative care model. So it started giving us a sense of like, okay, this works more or less. We understand how it works, but there are still certain things that are not maybe there are settings where this is just never going to work and they need something completely different. We also looked at the clinics that were still doing the model and still participating in this program. And they said over time, new barriers are emerging. Collaborative care was the new kid on the block in the beginning, but over time, people are getting hammered, and we have so many things to screen for, domestic violence and falls. Many of the patients want or need more intensive psychiatric treatment than can be offered in this program. When I spoke to patients, they said there was still this kind of stigma and fear, and you're left with the patients, maybe the late adopters who are still, the hardest to potentially engage. And what you start seeing over time is that, first of all, engagement is key to billing, right? So those clinics needed to keep bringing patients in to pay for those care managers. But over time, you see this kind of diminishing in improvement, fidelity, and reach, more importantly. So clinics went from having an average of about 130 patients per FTE to about 37 patients per FTE, as they, on average, this is across the state. And so I started looking again a little bit on one of my students looked at predictors of reach and effectiveness in the sustainability phase. This is now 2 years after, at least 2 years after you've implemented collaborative care. What's going on, right? And so what we found, one first is that there is this kind of back and forth between effectiveness and reach. The more people you were reaching, the less your effectiveness was. And vice versa, if you had really great effectiveness, maybe you were only taking care of a few patients. But there was this kind of sweet spot, caseload per FTE, which seemed to promote both. And that became a kind of a target for our later interventions as we've kind of progressed and worked in this area of like, we need to get at that sweet spot that kind of promotes both reach and effectiveness. We also looked at potential predictors of both, and it was clear that efforts to engage patients in a clinical session was associated with reach. Things like FTE, a smaller clinic size, non-FQHC were also predictors of reach. And then the one thing that seemed to be associated with effectiveness was the degree of psychiatric consultation, which was really interesting. And it gets to the fact that you can't really escape the fact that even in these models that we thought, a care manager could take over a lot of this work, having a little bit of a touch by a psychiatrist, and especially in the patients who weren't improving or they had questions on, having high rates of that was the number one predictor really of how effective that program was going to be. But when we looked at their rates 2, 3, at least 2 years in, the average reach was only about 13%. So they were only reaching about 13% of the patients who screened positive for depression and or anxiety in their setting. And their effectiveness rate had plummeted a little, went from 50%, not terrible, to about 44% on average in the sustainability phase. So we started thinking through, what do we need to do to kind of bolster or improve fidelity and reach and effectiveness in this population, especially in the sustainability phase. So what was really clear is that we had a really strong evidence-based intervention. It was widely adopted. As I said, 80% of FQHCs across the state were participating in this program. We got a sense of the mechanisms of action. It seemed to work by doing technical assistance and giving them some funding and training. It seemed to reduce perceived barriers around funding and knowledge, et cetera. But we also identified some unique barriers that seem to emerge in the sustainability phase, specifically around engagement, and also found that settings that maybe weren't working, where this just didn't work. And there were lots of opportunities. We had the financing, we had the partnerships, we had a pretty good strategy. So this is centralized technical assistance to help you with building blocks, but there was very little focus on how do we keep getting care managers to do the work that they're doing? How do we keep getting doctors to keep referring and seeing patients and titrating meds, get patients to keep attending collaborative care? How do we do that? And there had been very little kind of user-centered design and kind of targeting the intercontextual factors like the structure, staff turnover, that really just weren't well addressed by the technical assistance that had been provided. And then there was very little adaptation of the evidence-based intervention itself. Clinics continued to provide the intervention, collaborative care, exactly as it was in the original trials, which is a good thing, which can help with effectiveness. But over time, patients just needed something different. And so what that did is that resulted in very high adoption rates. We had great program delivery with Fidelity. You see this kind of early improvement in depressive symptoms, but then over time, you start seeing diminishing. Programs were still delivering collaborative care, but diminishing fidelity, diminishing reach and caseloads, marginal effectiveness. It became costly just because they weren't really seeing the return on investment. And so these are some of the things that kind of emerge in the sustainability phase. So we went back to our model and we said, okay, we've synthesized some of the prior implementation efforts. Now let's start thinking of ways to identify this from a behavioral perspective. We're trying to get these care managers to keep doing something. Physicians, what behaviors are salient? What are the behaviors that are salient for clinicians in this model? What are the behaviors that are salient for the patients in this model? What are some of the barriers to having those patients keep doing something? So really thinking about this from a sustainability perspective, and then identifying intervention functions, behavior change techniques that corresponded to those. And so we put together a multi-pronged approach. We had a mixed methods team, which was our core team that did a lot of the mapping and data analysis. We brought on a creative director who used to work for Coca-Cola. He's like, we're going to sell collaborative care to these settings, and started led the user-centered design aspects. We had an intervention team of physicians, patients, and care managers to make sure that the intervention and the strategy fit the local context, and then advisors, behavioral health experts to make sure that we were including the correct behavior change techniques, and then did user testing over and over and over again. We did this for every single level. And so I'm only showing you here the care manager and the patient level, but we also did this for the provider level as well. And so we came up with one discrete strategy. As I said, we tried to steer away from this kind of huge, multifaceted approach. We're going to find a more precise strategy. And so we decided on, instead of external technical assistance, we'd be doing more of a local technical assistance and infuse behavior change techniques into that. So making sure that we were very clear about problem solving, including a credible source, providing social support. These are all the things that kind of promote provider and care manager fidelity and collaborative care. And the sustainability tenets were really thinking about continued learning, continued evaluation, and adaptation of collaborative care over time. And so in order to make sure that this would keep going, even after we left, we incorporated this into an ongoing meeting that care managers were already having, I think every month at that time, and made sure that this was really targeting the key barriers of why it was so hard for care managers to do this work. On the patient side, based on all of our qualitative data, again, we tried to really focus on one intervention and included lots of behavior change techniques within it. It needed to have some verbal persuasion, information about consequences, and other behavior change techniques. Because the care managers were very motivated to bring more patients in, like I said, they had about 20 to 30 patients and they had capacity for about 100. They were much more motivated to distribute these, to engage patients, especially since it was so tied to reimbursement. So this is all part of the kind of user-centered design of identifying and trying to choose outcomes that were important to the healthcare system, the patients, and the providers. So we started off with something that was first we thought simple is better, and said, okay, let's just try something. We did some alpha testing, and then over time, we iteratively designed this over 3 different stages, and each time the usability improved, and we chose harder and harder, lower literacy individuals for that third version to actually go through. So usability was increasing, but in harder populations, older populations, as we kind of went on. And so by the end, this is what it looked like in terms of a more personalized experience. People said things like, I might already have a history of depression. Maybe I need or I've already been in therapy, or I'm currently in therapy. I need a completely different experience with a tool like this. Patients actually ask that we find ways to bypass the doctors as well. There is this kind of emerging thought that maybe the doctors were one of the main barriers to patients actually utilizing this evidence-based intervention. So making sure that we included some psychoeducation. Initially, we thought this would be shared decision making, but doctors are so busy, so we decided on making it more about activation, access to CBT apps, so that patients could use this and access treatment themselves without necessarily so that it was more personalized and patient preferred in terms of the type of treatment that patients would use. And so we went through this iterative process and focused on content and different procedures and different settings, making sure that this worked and not just the clinical setting, but community settings. We used electronic health record algorithms to identify patients, lots of different iterative procedures, think aloud processes to make sure that we were designing something that would improve the uptake of collaborative care from the patient's perspective. So this is just one category of theme. I think we had 8 or 9. So for usability, we have one for navigation and others. Of like version 1, people thought this is very difficult to use, but as we kind of went through, concerned about usability and older, we added and removed voiceover functionalities to try to find ways to improve, to simplify, improve usability in low literacy patients. So that by the end, it was much easier for people to kind of use, and that they could live link text messages, to care managers if they had questions and other components like that. We kept iterating this until we precisely targeted the barriers that patients said were the key barriers to them using collaborative care in the sustainability phase. And so by the end, we were only ready to go once we felt like pre-post in this population, we were seeing improvements in perception that cost, insurance, access, stigma, saw the biggest drop, barrier, improvement in attitudes or interest in antidepressants, decisional conflict, patient activation. And then we thought, okay, now we're ready for go live. And so we decided to choose the 3 lowest performing settings in this collaborative care program. So these clinics were providing data every quarter to the Office of Mental Health. And so it provided a great opportunity for us to compare our small pilot clinics to the rest of the state. And we randomized these providers, primary care doctors within these sites. And we really wanted to get a sense of, again, these multi-level strategies are often compared to just nothing. And so you don't get a sense of what worked, what didn't, what component was the most effective. And so our primary goal was to compare the depression care manager coaching strategy by itself versus depression care manager coaching strategy with an additional provider activation. So providers got a lot of the kind of behavior change technique, success stories, champion, feedback, education, feedback on their numbers of how they were doing, both asynchronous feedback and then synchronous feedback in the case of the tool. And then within this, we also randomized a subset of patients to either getting the tool versus nothing to get a sense of, does this tool actually work in real world settings? And then looked at a variety of settings. Like I said before, some of the problems with the field have been that we don't really understand why something worked or how it worked or what settings it worked best in. And so we did a multi-pronged approach to get a sense of like some of the attitudes, and we see a difference in certain barriers or attitudes, especially around engagement, that weren't there initially. So some of the early feedback is that in comparison to the rest of the state, the depth care clinics saw about a 10% improvement in effectiveness rates. Again, you have to remember that these are the lowest performing. So by low performing, we found clinics that had an effectiveness rate of less than 50% and a caseload of less than 60 patients per FTE, right? So these were the lowest performing clinics. And so in comparison to those clinics, we saw an improvement in effectiveness rate and then clinical contact, which I said was one of the direct ties to reach. In the low performing clinics during this time period, we didn't see any movement in screening. Effectiveness actually went down during this period of time, and then clinical contact rates stayed the same. We also compared our depth care clinics to the entire state. So all the clinics providing data, there were about 160 clinics that were in the sustainability phase of collaborative care. And again, those clinics saw no change in their effectiveness rates, clinical contact, screening, or any of the other fidelity metrics during this time. Then we looked at, did adding all the kitchen sink, well, not quite, the precise intervention for the PCPs do anything really, and really no difference. So having the care manager coaching meetings, really, we saw this again, this improvement in reach and improvement in adoption of collaborative care that was significant across the board pre-post, but not much of a difference when we added the provider level intervention. And we might have been a little bit underpowered for the provider piece. So really both showed, I think, improvement. And most of it we think is because of the care manager coaching and really nothing to do with all the things that we did to the doctors, nothing really worked in terms of getting them to refer more or to do anything any more differently than having just focusing on the collaborative care managers. How about adding the direct to patient tool? And so here we saw, so the darker blue is the intervention and the lighter green, as you know, Zool kind of thing is the control arm. We see higher rates of reach. So this is of the patients eligible for collaborative care, how many of them enrolled in collaborative care, started a new antidepressant, changed to a new antidepressant in some way, and how many of them actually enrolled. So we see almost a tripling in the rate of care of patients eligible for collaborative care who actually enrolled in collaborative care. We actually didn't see much of a difference for provider. So giving the doctors real time and letting them know, we gave your patient the tool, we've done everything for you. All you need to do is put in a referral. You don't even have to talk to the patient. The patient has already said they're interested in collaborative care, no difference in provider outcomes. So those patients were really accessing the care managers by bypassing the doctors in the end. So how about the mechanisms? When we examined we did some qualitative thematic analysis of the care manager coaching sessions. The key primary outcome was communication. And so those care managers were more likely to start messaging patients and PCPs, providing them more communication about how the patients were doing more work to engage the patient. So it does look like that was one key mechanism. And the other is adaptability, which is what we tried to do, right? So there were some things that were fixed, right? The fixed number of sessions. We tried to keep it, this was never going to be a long-term therapy, but things like trying to include sicker patients, adapting, they got more training in DBT and CBT. Before it was really just only problem-solving therapy to take care of a little bit of a sicker patient population. So making some changes was the other mechanism by which our coaching strategy worked, which is really the goal, and that's what we set out to do. But the things that were more moderators, there were times where resources continued to be an issue. Maybe a care manager went on leave or for pregnancy, for example. So there were things that they just couldn't control that continued to be, I think, moderators. And then the big preconditions for them is you still need to be screening patients so that we can refer them. And then PCP attitudes for them were one of the number one preconditions and barriers to the sustainability of collaborative care. And so this is a model that really requires primary care doctors to be on board. And so the fact that over time you see this kind of diminishing in PCP, no matter what the care managers did, there were some PCPs that would just never refer the patients. So we talked to the PCPs to get a sense. And what was surprising here is that the PCPs actually had very high acceptability, feasibility, usability was 9 out of 10 for the Net Promoter Score, appropriateness of collaborative care, right? So they scored very high. Everybody thought, I think collaborative care works. I'm aware of it. I think it's my responsibility. I think that the benefits outweigh the cost. I know how to manage mental health. I know what this program does. But there was a perception that there wasn't enough personnel, despite the fact that the care managers were wide open for therapy, number one. And then this relative priority, they still felt like they needed to prioritize heart failure and diabetes and burnout also. 100% of the intervention docs said that burnout is one of the main barriers for why it's so difficult for PCPs to, no matter what you do, to kind of buy into this program. And then in the intervention versus control, just as we predicted, we saw lower perceived barriers to treatment, high collaborative care acceptability, and interesting, significant differences in trust in the PCP. So those who got the tool were more likely to trust their PCP than those who did not get the tool. And so as we start putting this together, just to give you an example, as we start thinking through, it's clear that our care managers, there were high, you needed a engaged care manager, right? So the more engaged the care manager was, the better this entire process went. You need a collaborative care program in place that's billable. And so it seemed that we're improving some self-efficacy, that we're targeting communication, adaptability, if you think about CFR constructs, but the moderators remain like the more receptive the PCP, you can do all of this. You can get the care manager as activated as possible and as interested in doing, but if the PCP is not receptive, it's very hard to improve adoption, fidelity, and reach. And then that screening workflow also is a kind of a precondition for all of this kind of going as well as possible. So we started thinking, okay, it feels like using this model of our precise model worked. It allowed us to understand what happened, where, how. It allowed us to understand why our strategy worked. It allowed us to create a more precise strategy so that we weren't overdoing it, so that everybody was getting one strategy at a time in our multi-level strategy. And we thought, okay, let's try this in a more complex population, those with both coexisting depression and heart disease. And so this time, the other thought is that to add to our model, we thought, why don't we create something that's more generalizable? So not just for the local context, but based on a systematic review of all the barriers and facilitators for providing mental health treatment in cardiac patients. And so as you can see in our systematic review, we found one of my trainees looked at, the key pieces for providers. This includes cardiologists now, are still capability and motivation, right? And on the patient's perspective, it's still kind of opportunity and motivation as well, this kind of stigma and the need for personalized resources, et cetera. And so this time we said we're like, our patient level strategy worked pretty well. So we're going to adapt it for our cardiac population. So we did an iterative user-centered design process. We included a video, which is available on YouTube for, a man named DJ who goes through a heart attack and starts, it's like a little bit of a cartoon that starts developing some depressive symptoms that patients really thought was very, powerful, I guess, from their perspective. And so we said, okay, we're just going to adapt that because we thought our first patient level strategy worked pretty well. We also kept the care manager level strategy. We thought that worked. But we thought maybe we need to reinforce and this is the nice part about using the BCTs, because we got a sense of what are some of the barriers that still weren't being met here. And it's not acceptability. It's not like they don't know about it. They don't need any more knowledge. It's really about this kind of motivation piece and adding more prompts and maybe some feedback on behavior that wasn't really salient the first time. And so we again designed this multi-level strategy from the perspective of the care managers and staff, the providers, and the patients. Again, to try to find ways to activate and get them involved in not just now therapy, but and collaborative care, but exercise, any kind of exercise, whether it is cardiac rehab or others as another evidence-based intervention for depressed cardiac patients to see if we can improve the uptake of these evidence-based interventions. And so we just completed this trial. And so we did a kind of a modified stepwise design. If anybody's interested in more of the design of what we did, this was just published in the American Heart Journal. So across both cardiology and primary care clinics. And we instituted our problem-solving tools, this iHeart tool, and then within Epic, these kind of summary reports to cardiologists and PCPs, and then we're still waiting for our outcomes for depressive symptoms. We're starting to get a sense of what our implementation outcomes were. And so again, the conceptual model here is to be much more targeted in understanding. And, there are lots of reasons why things may not work the first time. Maybe you got the barriers wrong. Maybe you didn't understand the barriers the way that you thought they were. And so this allowed us to be a little bit more precise in targeting the barriers from the perspective of the providers and the patients. With the goal of really thinking about how do we improve depressive symptoms in cardiac patients. And so our preliminary results is that we did now see an improvement in referral rates, particularly in cardiologists, for either starting an antidepressant, referring patients to cardiac rehab, referring patients to collaborative care or CBT, which is what we hypothesized we would see, which is about a 10% difference. And then now an even more and maybe because they started so low, cardiac patients are have some of the lowest rates of mental health treatment out there. And so we saw this market improvement as well, more than double of reach, which is patients who actually objectively started some kind of new treatment, antidepressant, or cardiac rehab or exercise program. So right now we're in the midst of developing or disseminating this model. We are working on a stopwatch design across all of New York State of thinking through how do we provide the most salient parts of our intervention from the perspectives of the patient and particularly the care managers to include more behavior science in how we're building strategies to make them a little bit more targeted. And then we actually just submitted this working with computer engineers on an AI using more like Alexa and Google Play to do a better job of around the clock, more proactive, continuous motivational interviewing and CBT to kind of augment the therapy process. And so they provide some motivational interviewing, not just around therapy, but also around exercise and diet and some of the kind of mechanistic underplays around the relationship between depression and recurring cardiovascular disease. And let's see. And then the other piece that we're doing is my mentee has been doing a lot of more designing for implementation. I think there are now more and more frameworks. Ideas is an older framework. And more recently, there's been kind of a design for dissemination and sustainability to promote equitable impacts on health. And so for her KL2, which is now her first R01, really worked on looking at barriers to cardiac rehab, so clinic-based cardiac rehab and home-based cardiac rehab, especially during COVID, and thinking if I had to design this from scratch, how would I have designed this? And so designing or redesigning a hybrid cardiac rehab program that kind of really helps with reimbursement while also meets patients where they are, again, using the same model of user-centered design, behavioral theory, and some sustainability constructs as well. So perfect. I left enough time for some questions. In conclusion, I think there's been little focus on explaining why, how, and where strategies work or don't work. And there have been few multi-level precise solutions. And I think digital solutions are integral to sustainment, which requires not just financing and organizational change. We saw that in that collaborative care example, but attention to behavior change and adaptation. I do think that diminishing reach over time and PCP resistance, I would call it resistance. I have some stories that make me think that this is more resistance than something that's accidental, are under-examined in sustainability efforts. And if you're somebody who's working in collaborative care spaces, I think these really require maybe unique or new strategies in the sustainability phase. I think the strategies that work in the beginning may either diminish in effectiveness or need to be adapted over time or changed over time, and that they need to promote the adaptation of the collaborative care model itself and improve communication. And I also think that direct-to-patient activation and marketing, some of the limitations is that to get reimbursement, you still need to put a referral in. But I do think that there is doing more direct-to-patient activation and marketing for any of our both digital and non-digital evidence-based interventions, I think is really key. And finding ways to bypass very busy PCPs is something that needs to be kind of explored. I do think that it forces you to wonder, is it still evidence-based? Is it still the same model if the PCPs are completely bypassed? I'm not sure. We're starting to think about some de-implementation in settings where it's just a very poor fit. And maybe we need completely different models to replace collaborative care in some settings. And then I think some of the future directions are really starting to design for implementation and AI to, I think, have the potential to improve sustainability, especially if adaptation, updates, communication is kind of baked into those processes, which allows people to kind of continue using them long after kind of done. I'll make one plug for Luis Blanco, who's our creative director, who has helped us with a lot of our ideas, our designs, our communication. He's made himself available for folks who are interested in incorporating his input into the design of their interventions. He's been really great for us in terms of all of the different interventions that he's kind of been a part of. Yeah, he's been amazing. And then anybody who's also interested, I'm always interested in hearing what people are working on and collaborating. So I'm always happy to kind of hear what the center is working on as well. So thank you very much for your time.
Thank you. That was amazing. And hopefully you're seeing all these awesome claps flying through. What a wonderful showcase of an amazing program of research. Thank you. We have questions coming in, which is that you were closing on these points about AI, and someone had asked about what you and your team are thinking about related to the implications and dangers of doing that with therapy, which of course is a larger can of worms. But I think it's would love to hear some of your thinking on that.
Yeah, we just put in an application. I think everything, as you can see, our process is very slow. We really take our time with everything. And so, in partnering with folks, we're finding people who are willing to slow down, and don't want to put this into the market like tomorrow, for example. And so, we're working on more benchmarking of thinking through. They have this multimodal large language model, that has already shown some early feasibility and efficacy in terms of not only screening, helping with monitoring and screening, but then triggering CBT and motivational interviewing in patients. And high acceptability, patients seem to like it. And I think the next step is really starting to think through some benchmarking and trying these in much more controlled settings with sicker patients. So maybe under the auspices are, you have a psychiatrist who's also monitoring you and getting a sense of where is their bias. Because if you're only trying these models and testing them in like very mild patients, of course, in comparison to doing absolutely nothing, you're going to see some maybe improvement. And so I do think they need to be rigorously tested, but first it needs to be really intensive benchmarking, looking at bias, looking at like we have an ethics like guru on our team who's really going to be thinking through things like transparency. Where does your data go? How are you letting patients know where their data goes? And so, yes, I think the first part is really going to be doing some hard work of creating repositories of how to do this work or how to vet these models very well. I still think that I'm hesitant to think that they can be standalone models. And maybe one day, maybe I'm completely wrong, but I think finding ways to test them within existing models to kind of augment treatment, I think is really exciting.
Mhm.
Especially if you think especially I work with a lot of cardiac patients. If you think about it, the systematic reviews, you're only seeing, mild to very small to modest effect sizes for just regular therapy, for CBT, for even like, digital CBT. You're not talking about like, not everybody gets better. And so I think there's still a lot of room to start thinking about ways to kind of augment and improve those programs. But care managers and other social workers, therapists, psychiatrists will have to give input on how do you interact with those? What if the model tells you something completely different from what your therapist is telling you? It's like, how do you reconcile those two things? And I think access to data on the therapist side is something else that we're kind of playing around with. So yeah, we're still very much in the kind of how do we create benchmarks before testing the efficacy, and that's what the grant really is to do both, is to both test the efficacy against gold standard. And I haven't seen a lot of examples of saying this is just as effective as providing gold standard therapy or CBT or a collaborative care model. And so those are some of the things that we're kind of interested in doing on our end.
Um, as someone who also loves user-centered design, one of the things I love what you were just saying about the conflict and the ethics of when one person says one thing. I'm working with some physicians through their career development awards to think about from the clinician side, so predictive models that leverage machine learning. And so similarly, we're doing design work where, they're working on the model, but then how do you get clinicians to, implement that in practice and trust these models and trust the output, and really thinking about design methods as a tool to help people, to better understand that. And so just when you said the ethicist, it made me think, it really raises design questions around how you package that actually to be tangible and for the user.
Yeah, completely agree. And having them at the table from the very beginning helps in terms of, adoption and making it very right now, like the Epic is so convoluted. And so right now we're seeing a lot of these kind of predictive models. We're working on some of these ourselves too. Like, but you have to really look for them. They're so far away within Epic. And so finding ways to make it very easy for the clinician so they don't have to do all of this extra work, and having them at the table, I think is, but I think something else that you said is it doesn't just you can't just have anybody at the table too, because that can really affect your entire project. Like who you choose needs to be somebody who's well respected, who is kind of high up, who people trust. Like that's also, I think, a very key part. It can't just be like, I just picked any primary care doctor. I picked any patient as well. And so I think some of that is coming through in a lot of the work that we do too.
This dovetails somewhat funnily too. The next question from William Lever asking, what is the best way to sell bypassing PCPs within an implementation proposal?
Well, in a proposal, I don't know that I wrote it in the proposal. It's something that came out down the line, but I do think I wouldn't use the word bypassing, but I think we often include quotes from PCPs and providers in our grants, especially the PCORI grants, of like PCPs have said that this would be the best use case or the most helpful. And so finding ways to, and especially if I have my little theoretical model and showing them that, hey, I have some pilot data that shows that when we do direct to patient activation, we see some improvement in patient uptake or reach or effectiveness even of these models. I think that kind of sells it. So having some preliminary data, and I usually have quotes from PCPs and others who say this is for us by far the most helpful way for us to kind of our hands are full. We have so much to do. And if you think about it, when I think of and some of this is also an equity issue. If you think about it, most people can just find a therapist and go start seeing a therapist. But in a lot of our clinics, especially the Medicaid clinics, you need a referral in order to actually start seeing something that's more or less low risk. And it just ends up becoming yet another barrier, I think, in a lot of these models. So we're finding ways to also have the care manager put the referral in themselves. So all the PCP has to do is co-sign. And often PCPs will accidentally co-sign as they're closing their note. They're just trying to co-sign everything as well. So we're really trying to find ways or unique ways to think through how to do this. The other thing that question makes me think about is that if you think about it, we've also found that you don't always have to bypass the PCP. So targeting the patient to come in with a clear chief complaint, a PCP will always go down the algorithm in their head. So if the patient comes in saying, I'm depressed and I think I need to see something called a they will do it. They will, and so targeting the patient to say the right words to the PCP is something else that we're kind of playing around with. But yeah, you have to be careful about maybe using the word bypass, but I really think that.
They wrote back to say they like direct to patient
Oh,
activation, and we've
direct to
used the term
patient.
of
Yes,
thinking direct to
exactly. Yes,
consumer as well.
exactly.
And
Yeah.
what you just described, it reminds of, like a pharmaceutical model of back in the day, how I think about it. Like I see, online and then I go to Dr. Google and then I go into my doctor and, similar to what you're describing of
Yeah.
if we can activate and engage patients in having conversations with their clinicians, that's a real win.
Yeah. Yeah.
Um, Amazing. Well, we're just about at the top of the hour, and this was such a treat. Thank you, thank you. I'll close with just two upcoming plugs of our sort of sibling entities here at CBIT, which is that the Society of Digital Mental Health has, who is part of our webinar series, they have their annual meeting next week, and then the Single Session Intervention Conference, the fifth one, is being hosted by Jessica Schleider here in Chicago, and I believe there's still room to register. So that's at the end of June. So thank you
Great.
and
Thank
happy summer.
you. You too. Take care.
Thank you so much. It was a wonderful presentation.